Let me have again the honor to introduce our speaker for this topic, how to minimize the learning curve and avoid complications in vascular surgery. Our speaker for this topic is Dr. Sharon Kiang. She is the chair of the Division of Vascular Surgery of VA Loma Linda Healthcare System at Loma Linda, California. She is the Stenting Vascular and Endovascular Surgeon at VA Loma Linda, the chairman of the Institutional Review Board of the VA Loma Linda, and the director of the Center for Surgical Research Excellence, Loma Linda Surgery. And she is also the associate professor of the Department of Surgery at the same institution. So everyone, let us all welcome Dr. Sharon Kiang to talk on how to minimize the learning curve and avoid complications in vascular surgery.
My name is Sharon Kiang, and I'm the Chief of Vascular Surgery and the Chair of IRB at the Loma Linda Healthcare System. And I'm also Associate Professor and Director of Research for the Department of Surgery at the Loma Linda University School of Medicine. I have no disclosures. The contemporary focus of traumatic vascular injuries does emphasize endovascular methods. So the majority of this talk will focus on endovascular techniques and the complications that can arise from it. Now, endovascular management of arterial injuries has a lot of benefits. It's been reported to have reduced procedure duration, decreased blood loss, lower incidence of sepsis, and decreased mortality rates. The clinical complexity of the polytrauma patients does play into the judgment whether endovascular methods is the best method. And there are certain anatomic constraints of young vascular anatomy that does affect the efficacy and possibly the long-term results. The long-term efficacy, though, of endovascular repairs is currently being studied as compliance overall in the trauma population is poor, and the overall follow-up is estimated at only 55% at best in single-center studies. And one thing that to keep in mind is as we increase our techniques and increase our products and technologies for endovascular methods, we have to keep in mind the medical radiation exposure, not only to the patient, but also to the physicians involved. And especially as the trauma patients are younger, we have to think of different alternative ways for follow-up that may be a little bit different from the traditional vascular patient. This is an outline of the pathologies that we will cover today. We're going to start with a thoracic vascular trauma, which we will include in thoracic aortic trauma and Axillo-Subclavian innominate injuries. The cerebrovascular system with a specific focus on extracranial cerebrovascular injuries, and the lower extremity trauma. And we'll look at specifically some of the data looking at SFA and popliteal artery injuries. Thoracic aortic injuries account for 10 to 20% of all trauma deaths, second only to head injuries. And you see that there is a wide distribution of the vascular injuries in the entire thoracic aortic area, including thoracic aorta, subclavian artery, and carotid artery. Specifically for the thoracic aorta, the trauma can be related to either blunt or penetrating injury. For blunt thoracic aortic injury, the site of the rupture, majority of them, 80–90%, occur in the descending thoracic aorta, just distal to the left subclavian within 1 to 0.5 centimeters. And there's a 25% incidence of associated lethal cardiac injuries, especially related to this type of etiology. Now, another common area of injury is actually the descending thoracic aorta at the diaphragmatic hiatus, and that can also be very lethal. There are many ways to grade blunt thoracic aortic injuries. I have listed on the chart on the left the abbreviated injury scale, or the AIS, the Society for Vascular Injury, the SVS grading criteria of grades 1 through 4, and the Harper View classification. For the overall, the categorization, the majority of vascular surgeons like to use the SVS guidelines, which is categorized on the right. If you look and see, grade 1 is an intimal tear and grade 2 has an intramural hematoma. Classic recommendations include a watchful surveillance and a close examination and a repeat CT scan. A lot of times these injuries will actually resolve on their own. Now, when it comes to grade 3, it's a little bit controversial. It really depends on the exact nature of the injury, the location, and also what other associated findings you have. And then grade 4 obviously is a free rupture, and that mandates emergent repair. The current recommendation of repair for a blunt thoracic aortic injury is endovascular, if it is feasible. And there are several criteria that will have to be met, and several things to take into consideration to see if an endograft repair of a blunt thoracic aortic injury is a safe choice. One question that always comes up is what to do with the left subclavian artery. especially if the injury is going to require coverage of the subclavian for an endograft placement. And according to the Society of Vascular Surgery guidelines, is that in the event of a traumatic aortic repair, revascularization of the left subclavian artery is not necessary, and that the risk of spinal ischemia is low if it has to be covered. A lot of us will actually go ahead and cover it and then follow this patients clinically to see if there's any evidence of left upper extremity ischemia that will require vascularization, but a lot of times that is not necessary, and if necessary, it can actually be done after the traumatic repairs have been completed and the patient is stabilized. The other consideration when looking to see if an endograft is feasible is the integrity of the iliac vessels. You can imagine with the passage of the graft and also the deployment systems, if you have an iliac injury, it may be a contraindication, as you may harm the iliac system in trying to deploy the endograft and get the deployment system up. Now, having said that, I have listed a series of French conversions to millimeters, and I just wanted to point out that as time has gone on in the last decade and a half, that the deployment and profiles of available endografts for repair have actually gotten much smaller. And so most TVAR delivery profiles now range from 18 to 27 French OD. So if you look at, 18 up here, that's really only about 6 millimeters. So, it's significantly much more flexible in terms of iliac anatomy. And so it sometimes can be an option. Some things to keep in mind is a lot of us traditionally will actually anticoagulate patient before we put the size of the sheets up the iliac system to deploy the endografts. And that may not always be possible in the polytrauma patient given the associated injuries. So there are studies that are out saying that, given a quick deployment and if you actively flush out the delivery systems, anticoagulation is not necessary. So it is not always contraindicated that an endograft not be possible if the patient cannot be anticoagulated, is what I'm trying to say. So it's something that is still a valid consideration. And there has been some shift in the mentality about the timing of blunt thoracic aortic injuries. There is this original modality that they can be, waited on until other associated intra-abdominal injuries are fixed. Now, some of the studies coming out of vascular and trauma surgery now say that early repair thoracic injury reduces the hypovolemia time for trauma resuscitation, that you can actually, resuscitate the patient to a better degree than if they had a aortic injury that was waiting to be repaired. So there are certain data points that now say that early repair should be the standard. This is an example of one of my patients. This was a MVC, a young patient. And then obviously a patient came in with chest pain. The trauma CT noted a very large pseudoaneurysm. And you see that the proximal boundary of the pseudoaneurysm actually sits very close to the left subclavian artery. What I didn't show here is what I actually used IVUS to take a look. And actually I deployed a endograft and had the proximal area sit just distal to the left subclavian. What you should note here, however, is that in a young patient, the lesser curve of the aorta is incredibly acute, and that makes it very hard for the endograft to stay in place. And for this particular patient, on follow-up, the endograft did slip down. So I actually did have to extend the repair more proximal, cover the left subclavian, and have the proximal boundary just distal to the left carotid, common carotid. So it was an error on my part that I didn't cover it at the get-go. But this is an example of a young aorta where the aorta is very muscular and the lesser curve, which is the lower curve, is very acute. And when you have an endograft that sits right in the area, the risk of it slipping and actually falling forward is actually quite high. Now, there's some special considerations for the young aorta, as I keep mentioning. And young aortas are smaller, and we generally start dilating our aortas around our 40th decade, right? They become more floppy, they become less muscular. They, actually have the curve starts to lessen on the lower edge. And when you have traumatic injuries, it's not an aneurysmal pathology, right? So you cannot oversize your TVAR. That is generally accepted for the way you think about aneurysmal repairs. And, but that, it can be hard to estimate what their true size is, especially if the patient is a polytrauma patient and they're under resuscitated and their vessels are contracted. So you have to take that into account. And a lot of us, hedge bets about how to take a guess to see what the true diameter of that vessel really is. And as I mentioned, young aortas have a more acute angle of the lesser curve. And if you put too big of an endograft in because you think the patient's possibly hypovolemic and you want to just make sure that the graft sits right, you can have a complication called a bird beak. And on the CTA on the bottom right, you see the red arrow points to how the endograft doesn't actually hug the curve of the lesser aortic curve nicely, and it kind of juts out like that. And bird beaking actually is quite dangerous because, as you can imagine, with the forward systolic pressure that's coming from the central system, that it can keep pushing along the outer edge of that beak and eventually probably infold the graft and cause the graft to collapse. So then you end up with a completely collapsed aortic graft, and that can become a surgical emergency. So when you have a young aorta with a very tight curve, you have to select the proximal landing zones very, very carefully. And if necessary, cover the left subclavian. And then if even more necessary, you can debranch the carotid system if you have to. Now, I talked a little bit about long-term follow-up, and the bottom line is there is no good long-term data to look at this. As I mentioned, the trauma population is notoriously non-compliant. They tend to come in for repeat traumas, or they tend to be transient, right? They were traveling through and they actually came to your medical center, and the next time they have a trauma, they go to another medical center, and no one's really coming up to follow with anyone for surveillance CT scans. So I listed some of the reasons why there's no good follow-up as multifactorial etiology, like temporary locality of trauma, there's lack of compliance. There are some single center studies that have noted good technical success but have limited patient number and limited long-term follow-up. There's no way to know what happened to these stents as the patient aged and as the patient moved on, because they never came back for their surveillance CTs. And one thoracic aortic injuries is actually considered a low frequency trauma. And there was a meta-analysis done of 139 studies by Murad that noted a median follow-up of 2 years, and that was only for 15 patients, and that was considered actually a relatively good study. So it's very quite limited for what we have in the literature. One thing I brought up also was the effects of long-term medical radiation for the young population. It's relatively unknown, and so even if you have a compliant patient, are we really going to do a surveillance CT of this thoracic endograft for every year for the rest of their natural lifetime? It seems unreasonable. And that's a lot of lifetime accumulated, dose area products over, a lifetime, especially if it's a female patient. These are things to take in consideration. And the migration, as I mentioned, as the aorta dilates, as they get older, what happens to this T-bar? In theory, it should have actually remodeled inside the aorta, but we don't really know the data. So we don't really know what happens to these stent grafts that are placed in a young patient. And as they go through the progressive decades, what happens? The data is still unclear. I'm gonna move on to the Innominate Axillo-Subclavian system. And this is actually a pretty morbid injury as well, given the location. Injuries to the Axillo-Subclavian system is associated with high rates of morbidity and mortality. There was a study done by Dimitriades et al. That notes an overall mortality of 34.2%. And the open exposure of the left subclavian does require left anterior thoracotomy, so extremely morbid. And the right innominate and proximal subclavian requires actually a sternotomy. So again, very, very morbid. Now, when we think about the endovascular of the Axillo-Subclavian or innominate, there are some additional considerations that you have to think about. And one thing I always point out is where is it in relation, the injury, where is it in relationship to the thoracic outlet, right? Because we know that stents that are placed near in the thoracic outlet actually have a very poor patency, right? They get crushed very easily. So the thoracic outlet is a space formed by the anterior scalene muscle, middle scalene, and the first rib. And it's a area of high compression, especially on hyperabduction of the arm. So if you actually, use it to brush your hair, if you actually, use it to do anything like that, the compressive forces are quite high. And the stent placement in the thoracic outlet area have a very high fracture compression rate, and they frequently fail. And that's been very well established and very well published. So if the injury is anywhere near in the thoracic outlet area or included, it is not eligible for an endovascular repair. This is just breaking out the specific locations of the Axillo-Subclavian injuries into the left and right area. So if you just focus on the left subclavian artery system, if your injury is proximal to the left vertebral artery, the proximal landing zone has to be into the aortic arch. And you can flare the stent into the arch to make sure it actually maintains good hemodynamic flow. And the distal landing zone is proximal to the vertebral artery, just to make sure it stays open. If the injury is distal to the left vertebral artery, meaning past it distally, then the proximal landing zone can be distal to the vert, and then the distal landing is in the proximal to the thoracic outlet, right? You can actually try to land it just short of where the thoracic outlet actually opens. If you have an injury of the right innominate artery, the stent cannot cover the right common carotid, and you must take that into consideration into the risk of stroke as well. So if you cannot safely keep the common carotid safe, then an endovascular approach is not going to be a proper method. And as for the right subclavian proper, you can land it anywhere just distal to the right common carotid artery, as long as it doesn't involve the thoracic outlet. So those are just some of the more itemized details of how I think about putting a stent into the axillo-subclavian system. Now, this was another one of my patients that ended up coming in from a trauma, another really bad MVC, and this was the CT scan of the chest. I took him back and actually did a brachial cut down, and then actually shot a diagnostic angiogram, which is the diagnostic angiogram on the left, and you see there's a flush coming out of that axillary system. And the picture on the right is after I deployed a stent across the area. So some of the challenges, even though you think you have good landing zones, would be, what if I couldn't get the wire? What if it was a full transection? What if I couldn't get a through and through? And those are some things that that just happens, and you just have to, go with it and see what else you can do. But for this particular case, it actually it went quite well, and the patient actually did really well. Now, there's been a lot of talk about endovascular versus open repair, and there's been some attempts at trying to answer this question. And these are just some studies that, in the literature that report. Zenos et al. Reported a retrospective review of all blunt and penetrating injury. Endo repair, shorter operative time and less blood loss, and that makes a lot of sense. Carrick et al. Also reported the endo repair resulted in less brachial plexus injury compared to open. And that's something to keep in mind, is in trying to dig out the axillo-subclavian artery, especially if it's very proximal, that dissection is very morbid. And if you have a young, healthy male with a very well-developed pec and you've got a large hematoma, the possibility of actually having a nerve injury in your course of trying to dissect that and do the vascular repair is actually extremely high. And we looked at our own experience to see if it made a difference, and we did a analysis looking at the patients we pulled out of the Prove It registry, whether open or endo actually had any differences in repair and outcome. And we found that overall that the endovascular group had a shorter length of hospital stay, had a slightly reduced procedural time, and overall between the open repair, the group that was repaired open and the group that was repaired endovascular, there was no limb loss and no graft infections, and there's no vascular complications between the two methodologies. So it doesn't seem like, endo repair is a suboptimal form of intervention. Moving on to extracranial cerebrovascular injury. This is also another hot topic currently that's being investigated by the Society of Vascular Surgery. There is no real good criteria outside of penetrating injury. The blunt traumatic cerebrovascular injuries still lack some standardization, at least from the vascular surgery point of view. So when you look at these type of injuries, I've divided into two main categories: blunt carotid injuries, which can result in intimal flaps, dissections, and eventually development of a pseudoaneurysm. And then, of course, the more obvious penetrating carotid injuries that obviously can sometimes have free extravasations, expanding hematomas, complete transections, and obviously the associated injuries from the surrounding structures, which may include esophagus, trachea, etc. Now, some classic literature, when people talk about just, well, why don't you just go ahead and ligate it, is that, carotid ligation still carries a relatively high mortality. It carries a mortality of 40% and a cerebral complication of 30%. So it's not something that a lot of us immediately think is the only thing to do. We will try all our best to kind of maintain a revascularization approach. And surgical repair of carotid artery injuries still carries a mortality rate of 0 to 22%. It's not small. And post-operative progression of neurologic deficit is estimated at 0.0 to 21% when you review the literature. There are some specific anatomic considerations when you look to see how cerebrovascular injuries can be managed. And generally, injuries above the angle of the mandible are technically extremely difficult if you approach it open. And in the traditional way, before endovascular technologies, a lateral mandibulotomy urgently on table can get exposure to the base of the skull. If it's even higher than that, then it's going to be even harder. You're going to have to call in a neurosurgeon. And now with the advent of stents and even better stents and better understanding of flow dynamics of the carotid system, stenting is an option. So if you have penetrating carotid injuries to the skull base and above, they should be stented if it's clinically indicated. And everywhere else in the carotid system, the common, the bulb, the ICA, they can all be stented as well. Now, outcomes I touched about briefly. Mortality is relatively high in carotid injuries. The open repair can be as high as 22%. Carotid stenting is 0.9. Stroke rates for traumatic stenting in the context is high. It's 3.5% for neurologic deficits. It's much higher than elective carotid stenting. Because of different etiology. And there's some thought that this may be related to fresh thrombus in the actual context of trauma itself. The approach may also be contributory because most traumatic stenting is still done transfemoral. And so you have to take into account the disease of the aortic arch and what that plays into it. It shouldn't matter that much because these are younger patients. So there should be calcific disease, but if there's associated injuries, there could easily be fresh thrombus. The patency of carotid stent is heavily dependent on antiplatelet therapy, such as Plavix, right? We usually use aspirin and Plavix. And honestly, the compliance and even the prescription of antiplatelets to polytrauma patients is relatively unknown because of their polytrauma nature. They may not be eligible for the ability to take antiplatelets. And some things that take into consideration is also the experience of the interventionalists. And it really depends on the. So I'll just take over live at this point. This brings me to the last category of vascular injury, which is the lower extremity injury, which is the what we consider SFA and popliteal artery. Lower extremity arterial injuries, especially the popliteal artery, account for less than 0.2% of cases. It's actually in the population of trauma injuries, not the highest percentage of vascular bed that actually gets injured. But however, of those that get injured, the current lower extremity amputation rate is extremely high. It's 14.5 to 21%, depending on the literature that you're really looking at. And the amputation rate is 50% when the treatment is delayed by greater than 6 hours, but it can be decreased to less than 10% when revascularization is less than 6 hours. Again, right, this data is very hard to get extremely granular when it comes to so many different factors that involve the trauma patient. Now, a lot of people ask me, what is the approach now? Can we do this endovascular? And a lot of it has been written in the last decade about how endovascular management can be effective, but there still remains a lot of debate. And I will say that endo management of lower extremity vascular injury remains extremely controversial. And popliteal stents especially are vulnerable to extremely high mechanical forces if you think about where the popliteal artery begins and where it actually ends. And early series on, in our literature specifically, the failure rate was extremely high. And as the generation of stents have improved, some of that has actually gotten better. Next slide. But this is one of my patients, and I just want to illustrate something, is that not everyone, I think, who tries to do popliteal stenting really understands the contractile forces that are very, very specific to the sartorius Hunter's canal as it enters the popliteal fossa. So if you look at this angiogram, it's one of my trauma patients. On the angiogram on the left, you see this beautiful stent being deployed, etc. But when I check the actual flexion shots, right, when the knee is straight, the popliteal artery looks great. But when you look at the flexion shots, you see that the point of maximal exertion of flexion is not actually the area right behind the knee. is not truly in the infrapopliteal portion. It's actually in the P1 portion, which is the transition point between the SFA into the popliteal. So when you stent the popliteal artery, you cannot land the proximal stent in that area, which is going to be underestimated, right? If you don't know where the maximal point is. Now, the patency of popliteal stent, for example, again, just like the carotids, depend very heavily on antiplatelet therapy. Aspirin Plavix is pretty standard, minimum 3 months. Again, it's going to be a question of polytrauma patients. Are they eligible for Plavix therapy? And that remains highly debatable, and the data is extremely poor. Again, as I mentioned, because it's a flexion point, technical success is very, very dependent on understanding what the maximal flexion point is. So you really need a specialist to put these stents in, and they will have a good way to actually deploy it properly and also be later able to follow it properly on surveillance. And, you know, it bears mentioning that temporary stenting for immediate limb salvage is actually reasonable, right? Depending on the type of injury, depending on what else needs to be done. Temporary stenting, get the patient out of an acute limb issue, and then let him stabilize, get him resuscitated, and go back for definitive repair are also options. The picture on the right is actually a trauma patient of mine, and the orthopedic surgeon that consulted me really wanted me to save this limb. And I think it bears a very obvious mention that what you see there are multiple bone fragments, complete loss of tissue. There's nothing to cover anything, much less, you know, a stent versus a bypass. So this patient ended up getting a primary amputation by me. Now, I do want to end a little bit about infection. And this is something that I get asked a lot about, especially if you're looking at endovascular options for a penetrating injury, is that people always say, well, penetrating injury, that's a dirty wound, you're going to infect the stent. And I will actually say that, you know, that actually has not borne out in the literature, and what we can find, that has not actually been an issue. There's been no infected stents that we've had to go back to actually extract out, at least not the ones that we've looked at. And infection of a stent graft is a concern, but a lot of times I just want to point out it's outweighed by life-saving intervention. So of the very specific sites that I generally get asked about is, well, if you have a penetrating injury to the carotid, you have concomitant esophageal injury, you should not stent it. And my answer is usually is, well, infection is a problem, but let's save the patient first. Penetrating injuries to the aorta has a bowel injury, right? Sometimes, depending on if you're infrarenal, like you're not in the thoracic aorta. So that needs to be taken into consideration. But that data hasn't borne out either. There is data to show a stent in a stabbed injury to the abdomen doesn't get infected, and it can be a good temporizing measure. And then stent grafting for the common femoral artery, if there's associated bowel injury, things like that, or iliac arteries, I get asked about that a lot. And the bottom line is, you know, save the patient first in order to worry about the infection. So that's something I keep in mind, but it's always in the back of my head. And I think that's why compliance and follow-up is so important, because only, you know, the person who put a stent in can really know what they were really worried about. And I'm so sorry about what happened today in the presentation and the audio. But thank you so much for being so flexible, letting me talk the last couple of slides. Thank you so much.
Our reactor for this topic is Dr. Tiong Vune E from Malaysia. She's a general trauma surgeon at Hospital Tengku, Ampuan, Rahimah, Malaysia. She's a member of Trauma Society, as Trauma Surgery Society of Malaysia. She has an advanced trauma life support and care of critical ill surgical patient instructor. So everyone, let us all welcome Dr. Tiong Vune E.
Hello, a very good morning and good evening from Malaysia. I'm Yvonne Tiang. I'm a general and trauma surgeon in the hospital in Malaysia. Thank you very much for giving me the honor to be on this platform and a forum and to make comments on Dr. Sharon's talk. I think it was an excellent talk that covered a lot of things which I myself am not aware of. In my hospital, I do not have an IR, and I do not have endovascular services. So what happens is we do see a lot of peripheral trauma injuries, not so much about the thoracic ones. So what happens is our vascular center is about an hour's drive away. So instead of bringing patients over to them, we offer the services to them. So that I think it's a good thing for patient. I remember when I was first starting out, vascular injury can be a very daunting thing, especially in a trauma setting. But in view of the theme of this, it's going back to basics. So at the end of the day, for a vascular injury, it's essentially the main aim is to get flow back to where it actually has been interrupted. So it's just a peeling back all the fluff around it, and just make sure that you put in one perfect stitch after the other, and it's essentially peeling off everything and going back to the basics. Endovascular option is something that I've not been open to, but I find it very, very enlightening that it is something that it's a very good tool to have in your toolbox, especially for vascular injury, especially for thoracic injury. Just getting to the thoracic vessel itself, if you want to do it in an open technique, I think the access will be very, very invasive and can be potentially destructive as well. So I found your lecture to be very enlightening, especially in the finer details of the technicalities of what are the things you have to think about, the landing zones, and what are the outcomes as well. Finally, I think not last but not least, in a trauma setting, I think it's very important, as what you've mentioned, to actually keep in view a wider picture of it, because if you have a patient with vascular injury, it's usually not in isolation. So I think it's very important to actually keep in mind that what are the other things you have to deal with, and what is the timing of the repair. So all in all, thank you very much, Dr. Sharon, for your very enlightening, excellent lecture.